on the NewsChannel 5 network. This is OpenLine.
Hello everyone, welcome to OpenLine. Very good show tonight, very interesting show tonight, really an important topic. Glad you were with us. We're talking about a plan that would transform healthcare in Nashville. This is a plan for treating some of the city's poorest patients. It is being called bold, it is being called ambitious, and we really want to dive into it tonight, get a sense of how it would work and what it's all about. Happy to have with us Dr. James Hildreth. He is the president of Meharry Medical College. Dr. Hildreth, thank you for being here.
Thank you for having me.
So, this plan, let's say no one knows anything about it, 101, what is this plan? How would it work?
This plan is a proposal to integrate the vast healthcare resources in Nashville to provide the best care we can to indigent people who live in the city and the county. Nashville is blessed to have one of the most complete, robust healthcare infrastructures actually in the world. People may not know that there are, hundreds of healthcare companies here in Nashville. 17 of them are publicly traded. It has a total economic impact of $92 billion and accounts for over 500,000 jobs in the country and around the world. So if we can do this anywhere, Nashville is certainly a place where we can develop a plan to take the best care of indigent. I need to remind people that indigent does not mean poor, because there are some people who have insurance, but because they cannot pay the co-pays, they don't make use of their insurance. So it's not just poor and destitute individuals, it's actually working people, some of whom have insurance, but they can't afford to use it because the co-pays are so high.
So many people have these high deductible plans that are really, really high deductibles. And so they're scared to go and get care, and when they do, I guess they can't afford it.
They can't afford it. And so in Nashville, there are about 109,000 individuals who fit that description. And some of them are working every day, contributing to our economy. And I think I was very heartened that last March of 2018, the people of Nashville spoke very loudly that we need to take care of these individuals in a poll that was conducted by Vanderbilt. So
how are these people right now being cared for? It's through Meharry, right?
Well, Meharry contributes to their care, but honestly, a lot of these individuals show up in the emergency departments of the 3 large hospital systems. As a matter of fact, between Vanderbilt, St. Thomas, and HCA, somewhere between $150 million to $200 million is written off in charity care every year, because these hospital systems are providing care that they never get paid for. But it's fragmented, it's disconnected, it's not integrated, and so you end up spending a lot more money to take care of these individuals rather than having them in the care of a primary care provider or someone who can manage their care.
The idea behind this plan is to divide it among all of the hospitals. Is that right?
Well, the plan is really to establish a collaborative network of care for the full spectrum of care, continuum of care as we call it, from preventive medicine or preventive kinds of things that we can do in terms of vaccines to the highly specialized care. For example, if someone needs spine surgery, that is not something you would want to be done in the safety net hospital, because the cost of doing so in that setting is much higher than at Vanderbilt, HCA, or St. Thomas, where they have special teams to do it. So the idea is to make sure that care is taking place in the most appropriate place for the best care and the lowest cost. And that means having a collaborative system that's integrated, asking each component of the system to do what they do best. We're not going to ask them to do any more than they're doing or anything different. We're just going to connect it into an integrated system that provides the best care for everyone.
And so now, that's the hope.
Yes.
What happens now?
What happens now is that individuals who don't have insurance will wait until there's an emergency situation, and they will show up in an emergency department, right? For some of those individuals, if they were under the care of a provider, some of them would never reach the point of having to go to an emergency room, where taking care of them can be as much as 10 times more expensive than if they were in an ambulatory clinic somewhere. And there are lots of examples of that. So what happens now is that the system is fragmented, and the other thing that really creates a challenge is that when an individual goes to an emergency room at, say, at Vanderbilt, but then shows up at an emergency room at Nashville General, the information doesn't follow them. So there's duplication of information and effort that also adds to the cost of taking care of them. So this system would provide a method by which individuals could go to a primary care setting, get evaluated, and then refer to the appropriate setting for whatever care they need to manage the cost and make sure they get the best care.
What brought this on? You started thinking about this when?
Well, the precipitating event was on November the 9th in 2017 when former Mayor Megan Barry announced that she thought it was time to close inpatient services at Nashville General Hospital. And I know there was concern about the low patient census. There was concern about the quality of care being delivered. There were lots of questions. And I believe that the mayor felt that because we had developed a partnership with HCA, that perhaps it was the right time to close inpatient services at Nashville General. So it was devastating from the point of view of the care we could provide for individuals, but devastating for the future of the hospital and Meharry Medical College. So I thought, given where we are and who we are and what kind of city that we are with all these resources, this might be the perfect time to look at indigent care overall rather than just focusing on the hospital. And in our model, the safety net hospital is the hub. So we're going to make the best use of the existing safety net hospital, but make it part of an integrated system of care. So the precipitating event, or the reason why I proposed this, was in response to the proposal that was made by the mayor at that time.
And you remember the date?
Date and time.
What did you think when that proposal, what happened?
Well, Nashville General has been an anchor in that community for, 3 decades now almost. And it is a place where really excellent care is provided. The people in the hospital are committed to the patients, they're committed to the mission, and that mission aligns perfectly with Meharry Medical College. And since 1993, Nashville General has been our teaching hospital. We cannot be an accredited medical school without a teaching hospital, without an anchor hospital, and Nashville General is that for us. And so we have a relationship in which the hospitals provides the support for physicians, and Meharry has provided to physicians, and the combination of those two makes for an integrated delivery service that takes care of people who come there. And so if the hospital had closed, it would have been devastating to our community, but also devastating to the future of Meharry Medical College. And so the idea was to come up with a plan that preserved the hospital, preserved the future of Meharry Medical College, but provided the best care for the indigent of Nashville.
And talk a little bit about, I guess, the number of people who go to Nashville General and its role. Again, the event that kind of got everyone thinking about this and got you thinking about this was that it was going to be closed.
Right.
Mayor Barry said it's expensive and we're going to close it. And it was not. It was met with a lot of opposition.
Yes.
But it is, if one mayor was going, and it didn't happen, obviously, but if one mayor is going to propose that, it may happen in the future. So you're thinking about that, but what is the role of Nashville General? How many people does it see? Who is it seeing? Tell us about that.
Well, clearly in comparison to the big three, as we affectionately call them, Vanderbilt, HCA, and St. Thomas, the number of encounters and patient visits is rather small by comparison. But the individuals who come to Nashville General, they come there because of convenience, because of the commitment we have to take care of those individuals who cannot pay for the services. They get treated with dignity and respect and all this. Not to say they wouldn't at any other place, but we provide a welcoming, sort of very nurturing and supportive environment to take care of those individuals. Because Nashville General attracts staff members who are committed to that mission of taking care of the underserved, and it's been doing it for a long time. And we're really proud of the fact that they're our partner and that we have the same mission. So there's this synchrony in our mission that has worked really well, and we'd like to continue that. But it will be devastating to our community if the hospital closed, because there are lots of jobs there. As a matter of fact, between Meharry and Nashville General is one of the economic powerhouses of that community. And if you closed it, the economic impact alone would be quite significant. But more importantly, the future of Meharry Medical College as an accredited medical school would be in jeopardy as well.
So obviously, Meharry needs Nashville General. the community needs Nashville General.
Yes.
It costs, I guess Metro gives it a payment, a subsidy.
There's a subsidy.
So Metro is paying money to keep it operating.
Yes.
And how, the plan that you're talking about, what happens? Does Metro still pay a subsidy, or that subsidy goes away?
One of the important next steps in the proposal is that we seat an implementation team whose job would be to identify the best funding mechanism to make this system sustainable. One of the charges that I gave the group is to try to do this in a way that at a minimum would not cost the city any more money, but over time would actually reduce the subsidy. And that would be achieved by making the system attractive to individuals who can pay and do have insurance. That's our goal. We want to create a healthcare system that's so attractive, that offers such a high level of service, that not just the indigent would be attracted to it, but people who could pay and have insurance. In that way, the system would become self-sustaining because we're taking care of individuals who do have insurance.
And tell me if I'm wrong here. And all right, so right now, Nashville General is treating primarily almost everybody that goes there has no insurance.
Oh no, that's not.
So that's wrong. Okay.
That's wrong. In fact, some Metro employees use it. Some Meharry's employees use it. There are a lot of people who use Nashville General because of the level of service and the commitment they have to their community. But we owe it to those individuals and to everybody else to make sure that the care they get when they come there is the best it can be. So it's a mistake to think that only indigent come to Nashville General, because people with insurance and who self-pay do come there as well.
A large number of indigent go to Nashville General.
Yes.
And the goal with this would be to kind of disperse that, right? Have other hospitals in our city, and we're blessed with many, share that load.
Well, as I said earlier, we would not be asking the large hospital system to provide any more indigent care or charity care than they're already doing, because they do a lot. And as a matter of fact, at a minimum, it's probably about $150 million worth of, and by comparison, the subsidy that the city pays to the hospital is only about $45 to $55 million. But there is still a need to have a safety net hospital that can take care of a certain proportion of those individuals. And the idea would be to identify the service lines that are most appropriate to Nashville General, but then when you have more special needs, as I said before, like a transplant or spine surgery, the big three would be a much better setting for doing that, because they have teams in place already who can do that at the lowest possible cost. And the whole idea here is to make sure we're doing things in a setting where the cost is going to be lower. And we want to have people know that they're going to be paid for those services. It's not that they're going to be doing charity service. We're going to be negotiating contracts with them to provide those services to the indigent at a pre-negotiated rate. So they're going to be paid for the services. We're not asking them to do more indigent care than they're already doing. What we're asking for is an integrated network where the services provided are in the best context in terms of quality of care and cost.
What reaction have you gotten from the other hospitals? What reaction are you getting with the plan?
I think all of them agree that having an integrated system to take care of indigent people is a good idea. I think they've all agreed to the concept of this proposal. But there are so many policies and regulations and laws related to delivering health care that there has to be an implementation team to make sure that we're doing things that are in compliance with all the laws and regulations that are out there. For example, one of the models that is proposed in this document is that the hospital systems, the large hospital systems, transfer low acuity patients to Nashville General.
And low acuity means what exactly? Low
that
acuity
means that people who are least ill, who can be taken care of in settings that don't require specialized teams.
And a lot of nursing care, probably, right?
Yes, but they still need to be hospitalized. They need to have inpatient services, but at a lower acuity than some patients who had a transplant or trauma or that sort of thing. And the reason why they might agree to do that is that it frees up some of their beds to do more of what they do best and transfers patients to a setting where they're going to get excellent care, but in a lower acuity setting than they would be if they were in those systems. But even that has to be negotiated because there are some laws like EMTALA. EMTALA requires that if you're a hospital that receives payments from Medicare, you cannot turn anybody away who comes to your emergency room with an emergency situation or a woman in labor. You have to treat them, stabilize them before you can send them. So those are the kinds of things that we have to work out that the implementation team will have to deal with. But as a concept, I think that in my conversation with the leaders of those systems, they agree that conceptually it is something that they could actually agree to, but there are lots of details to be worked out.
Right. But it would, there would be more sharing.
Yes.
Is that a fair way to put it?
Yes.
Yeah.
And the idea is that you create an indigent care fund so that people understand that you're not going to be offering any more charity care because these patients will be paid for. The services will be paid for, but we're going to make sure the services are delivered in the best possible setting in terms of the care and the cost.
All right, that kind of sets the table. It's very significant. It is bold, and I feel like it needs to be talked about even more. But I want to take your calls. There's the number, 615-737+, 615-737-7587. If you're on the line, hold on. If you want to call in, that is the number. We'll take a break. Be back right after this.